So let us now go to a discussion of the test for cholestasis or reduced bile flow. So enzymes released as a consequence of decreased bile flow include your alkaline phosphatase or the 5' nucleotidase or leucine aminopeptidase and your gamma glutamyl peptidase or your GGT. And there's also usually accumulation either in the liver or in the blood of substances that are normally excreted in the bile. For example, your bilirubin or your bile. So these are the affected enzymes and substances whenever there is cholestasis or reduction in blood flow. Your serum alkaline phosphatase, so your ALP, actually comprises a group of isoenzymes derived from the liver, the bone, intestine, and placenta. So your alkaline phosphatase is found not only in the liver, but also in the bone, intestine, and placenta. Your hepatic ALP, or your alkaline phosphatase, or as we call it, your isoenzyme ALP-1, is present mainly in the mucosal lining in the bile ducts. So it's usually found along the mucosal lining of your biliary ducts. The usual flow of bile into the small intestine maintains the normal serum level of your alkaline phos. In situations or conditions of cholestasis related to biliary obstruction or duct injury, serum alkaline phosphatase level usually rise as a result of retention of bile acids in the livers because the bile acid cannot be eliminated from the liver. Then the bile acid solubilizes the alkaline phosphatase from the hepatocyte plasma membrane. So they are, remember your alkaline phosphatase align the mucosal lining of the bile ducts. But since the bile acids are retained, there's reduction in blood flow. These bile acids, tinutunaw niya, no? Solubilizes the alkaline phosphatase from the hepatocyte plasma membrane. And also, it also stimulates the synthesis of your alkaline phosphatase. So various other hepatocyte plasma membrane enzymes are also simultaneously released, no, together with your alkaline phos. And this include, as I mentioned earlier, your 5' nucleotidase or your 5' NT and your gamma glutamyl transpeptidase or GGT. So confirming that the elevated alkaline phosphatase is actually caused by your hepatobiliary disease. So these two markers can confirm that the elevation in alkaline phosphatase is coming from your hepatobiliary condition. So the measurement of alkaline phosphatase is thus correlated, no, with the integrity of your biliary system or your bile ducts. So conditions or diseases like your primary biliary cirrhosis or PBC and primary sclerosing cholangitis or PSC uh, are examples of obstructive diseases with predominant elevation of your alkaline phosphatase. On the other hand, other conditions such as bone regeneration, pregnancy, and even cancer, no, neoplastic, infiltrative, or granulomatous liver diseases are also associated with elevated alkaline phosphatase. So if you have an isolated alkaline phosphatase level, this may be the only clue, no, to obstruction of the common bile duct or of the presence of neoplasm or cancerous growth or granulomatous hepatic disease. So elevated serum ALP with normal 5' NP and GGT will usually suggest a non-hepatic cause. So pag normal yung ano mo, 5' nucleotidase and your gamma glutamate transferase, this usually suggests a non-liver etiology of your problem. Example, it could be bone disease, it can be pregnancy, it can be due to chronic renal failure, or lymphoma, or congestive heart failure. So electrophoretic fractionation, or let us say separation of the different alkaline phosphatase isoenzymes may be useful not to confirm these alternative sources of your elevated serum alkaline phosphatase. So this picture here on your slide actually is shows to you the location of your alkaline phosphatase at the canalicular or apical membrane of your bile ducts. So your bile ducts, the biliary wall, no, of your biliary system, uh, have a proliferation of your alkaline phos substances. So if you have obstruction of your biliary system, of your bile duct, and then it will lead to elevation of your alkaline phosphatase kasi yung mga nasa membrane ng bile duct will be solubilized by the bile acids that accumulate in the obstructed structures. So your elevated bilirubin levels, so hindi lang bile acids, ano, pati na rin bilirubin, are also elevated in conditions of cholestasis. So bilirubin is present in the serum in two forms. Now you have your unconjugated form. You call this your indirect bilirubin, and your conjugated form or direct bilirubin. So under normal conditions, your total serum levels of bilirubin usually are less than 1 milligram per deciliter. So normal baseline levels of your bilirubin levels should be below 1 milligram per deciliter. And about 30% of this bilirubin levels are made up of conjugated fraction, or your so-called direct bilirubin, which are uh, soluble, no, water soluble, because they are already conjugated in the liver. The serum bilirubin levels will reflect a balance between bilirubin production and its conjugation and excretion into bile by the liver. So if you remember, first year uh, subjects, your bilirubin are normally products of the breakdown of your senescent red blood cells, no, your RBCs. And the old aging RBCs are broken down by your macrophages, and hemoglobin moiety is separated into the heme component and your globin component. And the heme component is the one that gives rise to your bilirubin. So there is a normal level of bilirubin production from the breakdown of your hemoglobin from your senescent RBCs. The differential diagnosis for elevated bilirubin levels requires consideration of your a list of disorders in which there are alterations of bilirubin production. Uh, Basically, these are conditions or disorders with predominantly unconjugated hyperbilirubinemia, no? O yung mga direct indirect levels, no, of bilirubin that comes from the breakdown of your hemoglobin. This can also be due to hepatic metabolism or due to congenital abnormalities of bilirubin conjugation, like liver disease, no, like your Crigler-Najjar syndrome, no, or your Rotor syndrome, or the excretion problems, for example, congenital abnormalities of bilirubin excretion or biliary obstruction with predominantly conjugated hyperbilirubinemia. So your alkaline phosphatase, on the other hand, as I mentioned earlier, originally is an enzyme, and this is increased by cholestatic liver diseases, including obstruction, other condition that damages, no, or obstruct the biliary duct. So they come from the apical membrane of your hepatocyte and bile duct cells, and they are very sensitive to any changes in bile flow. Obstruction of large or small bile ducts can lead to elevations of your alkaline phosphatase. And they're also amplified by bile acid retention kasi sabi nga natin kanina, when bile acid in the biliary tree accumulating, they solubilize, no? Tinutunaw nila yung, tinatanggal nila yung alkaline phosphatase na naka-attach sa membrane ng ating mga, sa wall ng ating biliary duct. And it is easily released into the blood as it is a G protein anchor solubilized by detergents, which is a characteristic of your bile acid. And we can also take note that your alkaline phos is easily measured spectrophotometrically, just like your other substances in the liver. And as of now, they don't know yet what's the function of your alkaline phosphatase in the body. There are some research that that supports the idea that they somehow contributes, not to the detoxification of the body of substances like your lipopolysaccharide uh, or LPS from bacteria, which is a potent toxin, no, in the body. So these are different uh, concentrations of your taurocholic or your bile salts, and different levels of concentration will lead to an increased production of your alkaline phosphatase molecules. So change in the alkaline phosphatase and your 5' nucleotase activities of adult rat hepatocytes in monolayer culture after 24-hour oxidation with taurocolate is shown in this figure. So the more concentrated is your bile salt, the higher is the production of alkaline phosphatase molecules. Also, your alkaline phos is implicated in various liver diseases. So elevation of your alkaline phosphatase is highly variable depending on the duration and extent of your cholestasis and other unknown factors. So here in this figure, you'll see that long-standing bile duct obstruction can have a very high elevation of your alkaline phos compared to acute bile duct obstruction, and even higher compared to your mild early partial duct obstruction. And usually alkaline phos, although it could also be elevated in hepatocellular diseases, uh, the elevation of your alkaline phosphatase in hepatocellular diseases is not that high compared to the elevation of your alkaline phos in conditions that are associated with bile duct obstruction. So when you have the alkaline phos result of the patient, how do we interpret the result? So interpretation of elevated levels of alkaline phosphatase can lead to a conclusion that there is a presence of cholestasis, especially in extrahepatic obstruction. You can also interpret it as a presence of possible infiltrative diseases like your granuloma, and even one of your differential will be the presence of neoplastic diseases, cancer that are infiltrating the liver. Sensitive test will go up if only some small ducts are obstructed. So this is a sensitive test, even though only some small ducts are obstructed, your alkaline phos will be elevated, even if there's only partial obstruction of the major ducts. However, the disadvantage of your alkaline phos is that it's not completely specific to your liver because other isoenzymes of your alkaline phosphatase are also present in other organs, as I mentioned earlier, including your bone, intestine, and your placenta. Therefore, it can also be implicated in bone disease, intestinal obstruction, and even pregnancy. Now let's go to your serum bilirubin. We have talked a little bit about this kanina, your bile acids. And why do we measure serum bili in your liver function test? So liver is virtually the only mechanism for your bile acids to be excreted from the body. No? So the only way the body can eliminate bilirubin is via the liver. So cholestasis from any causes will result of the backup or accumulation of these compounds in the blood. And usually when we look at your serum bili or bilirubin, they can say that if there is elevation of your bilirubin, this cholestasis or obstruction in the bile flow can either be intrahepatic or the problem can be within the liver or extrahepatic, it can be outside of the liver. So the disadvantage of your serum bilirubin is that it could not distinguish your hepatocellular diseases like your hepatitis, in which hepatocytes don't make bile from bile duct obstruction. So that's one of the things that you should take note of with regards to your serum bilirubin. Another reminder is that your bilirubin, based on our biochemistry discussion, is an organic anion, and as mentioned earlier, it's actually a byproduct of the breakdown of your old red blood cells, particularly the breakdown of your hemoglobin moiety. So in animals, particularly mammals, bilirubin must be conjugated to glucuronic acid in the liver and excreted in the bile. No? So blood levels will go up if any steps in the production or hepatocyte excretion are altered. However, obstruction of the level of bile ducts must be complete or virtually complete for bilirubin levels in the blood to change. So unlike your alkaline phosphatase, as mentioned earlier, bilirubin levels are not very sensitive to obstruction in the bile ducts unless there is complete or virtual complete obstruction, no, for your bilirubin levels in the blood to change. So this is a schematic diagram of your hepatic bilirubin transport and how it originates from the breakdown of your red blood cells in the reticuloendothelial system, and the breakdown of your heme moiety will lead to the production of your unconjugated bilirubin. And your unconjugated bilirubin is not water soluble. It's lipophilic. It's fat loving. So it in order for it to circulate in the blood, it needs to be attached to a transporter. And the transporter is your bilirubin. Of your bilirubin is your albumin. So the large portion of your unconjugated bilirubin in the circulation are attached to your albumin. And then it is brought to the liver and it is transported inside to the hepatocyte. And in the smooth endoplasmic reticulum, your unconjugated bilirubin is processed and conjugated with your UDP glucuronide. And the product of that process is a conjugated bilirubin. And this conjugated bilirubin then is released into uh, the bile canalicculus through a transporter, which is an active transport using ATP, using your MRP-2 multispecific organic anion transporter. So you have your conjugated bilirubin together with your glutathionase conjugates and other organic anions being excreted together with the bile, no, into the biliary tree. There are many diseases that can affect these processes, and some of them are shown here in the slide. Conditions like your Gilbert syndrome, this is a mild disease, can affect, no, the conjugation process of your bilirubin inside the hepatocyte. So because it depress or makes the activity of your UDP glucuronate less. So your Gilbert syndrome and your Crigler-Najjar syndrome uh, can both affect the conjugation of your bilirubin in the hepatocyte. Your Gilbert syndrome usually is mild, while your Crigler-Najjar syndrome is usually severe. No? These are due to genetic uh, etiology. No? But the bottom line is that they interfere. No? These diseases interfere with the normal conjugation of your bilirubin from the breakdown of heme product. Other conditions like your Dubin-Johnson syndrome, your Rotor syndrome, could be mild forms of etiology of liver diseases that affects the excretion or, you know, the transport of your conjugated bilirubin into the biliary tree, because they interfere with this multi-specific organic anion transporter. So as a result of the problem of transport of conjugated bilirubin, the conjugated bilirubin will accumulate in the hepatocyte, because the hepatocytes, remember, are in close contact with the sinusoids, no, through the space of DC. Then you have the vascular supply, so they could easily leak out from the hepatocyte because there's an accumulation of your conjugated bilirubin and be transported into the systemic circulation, leading to hyperbilirubinemia. So for the mechanisms of hyperbilirubinemia and liver disease, the overall rate limiting step can be found in the um, transport of your conjugated bilirubin into the biliary tree. And remember, when the conjugated bilirubins are elevated as a result of problems in the transport or excretion to the biliary tree, they will leak out into the circulation, and your conjugated bilirubin will bind with your albumin and be circulated, you know, into systemic circulation. So how do you interpret elevation of your serum bilirubin? Your serum bilirubin, if there is elevation, you have to identify which fraction, no, of your bilirubin is actually elevated. Is it the conjugated fraction or your unconjugated fraction? Your conjugated fraction is your uh, non-water soluble lipophilic form, while your unconjugated fraction is your, no, no, your conjugated fraction is your uh, water soluble, no, or soluble uh, fraction of your bilirubin, while your unconjugated is your uh, insoluble fraction. So if you have an elevation of your conjugated hyperbilirubinemia, we can say that your bilirubin will reach the liver, was conjugated, not excreted in the bile. And there are conditions that will lead to this, including cholestasis or biliary obstruction kung nakabara yung biliary tree. So as you have mentioned earlier, the obstruction must be essentially complete, no, for the bilirubin levels to increase in the blood. Also, hepatocellular damage, for example, you have a general damage to the liver, collateral damage to all liver function, then the bile formation will be impaired. Remember, bile formation is in the liver, and then therefore conjugation will also be impaired. There are also some rare disorders of involving your canalicular secretion of conjugated bilirubin, and this will lead to elevations of your conjugated bilirubin in the blood. On the other hand, your unconjugated hyperbilirubinemia uh, can be due to the fact that bilirubin did not reach your liver efficiently or was not conjugated, no, in the liver. And this can be due to several conditions, including massive overproduction of bilirubin material coming from acute hemolytic processes. No? There's acute hemolysis, or you have presence of diseases like sickle cell diseases that has increased hemolytic processes. No? And so there's a lot more red blood cells that are dying and are being destroyed, and therefore there's a lot of hemoglobin moiety that will supply, no, your bilirubin production. There can also be impaired conjugation, as we mentioned earlier, like your Gilbert syndrome is a common condition that impairs, no, conjugation of your bilirubin in the liver. Uh, the more severe form is your Crigler-Najjar syndrome, uh, but it is more rare compared to your Gilbert syndrome. So your bilirubin undergoes a non-enzymatic reaction with albumin, and your bilialbumin conjugate is also called your delta bilirubin. So your bilirubin plus your albumin, when it is released into the circulation, is called your delta bilirubin. So why is your bilialbumin of clinical interest? Why are we talking about the bilirubin that is bound to albumin? Actually, this is not of interest during liver disease, no? As this form of bilirubin is measured as, is classified as part of your conjugated bilirubin. However, after resolution of cholestasis or liver disease, bilialbumin is cleared like albumin, no? So uh, it will follow the half-life of your albumin. So your albumin half-life is generally several weeks. Normally, your conjugated bilirubin's half-life is just hours to days. So therefore, the resolution of jaundice is often slow compared to the improvement of other liver functions because your bilirubin stays in circulation for a longer period of time because it is bound to your albumin. So, nag-improve na yung ibang markers ng liver problems natin, but because your bilirubin is still bound to albumin, and albumin has a half-life of several weeks, no, compared to hours or days only for conjugated bilirubin. Therefore, that level of bilirubin in the blood is not easily eliminated. And therefore, there's a prolonged resolution of jaundice when you have this situation. All right. Let us now go into an understanding of, of the liver function or dysfunction using your quantitative liver test.